Hi, everyone. Welcome to today's webinar. We're going to just give everyone another minute or so to get finished logging on, and then we'll begin the presentation. All right, let's get started. Welcome to the webinar, New Developments in the Screening and Treatment of Ovarian Cancer. I'm Maggie Nicholas Alexander, Ovarian Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, and uterine cancer for the last 44 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs. All services are free of charge to participants. For more information, visit our website at sharecancersupport.org. This webinar is being put on in partnership with FORCE. FORCE's mission is to improve the lives of individuals and families affected by hereditary breast, ovarian, and related cancers. To learn more, visit their website at facingourrisk.org. All participants will be muted during the presentation. When Dr. Levine finishes presenting, we will begin the Q&A discussion. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Now I'd like to introduce our speaker. Dr. Douglas Levine is a board-certified gynecologic oncologist who specializes in the surgical treatment of women with known or suspected ovarian and endometrial cancers at NYU Langone Health, where he serves as the Division Director of Gynecologic Oncology. In his laboratory at NYU Langone's Perlmutter Cancer Center, Dr. Levine focuses on precision medicine, rare tumors, and early detection and prevention of gynecologic cancers. His team is currently leading a national clinical trial studying ovarian cancer prevention through removal of the fallopian tube. They are also working to understand which women are most likely to respond to treatment with anti-cancer drugs so we can direct the best treatments towards the most appropriate patients. Great. Thank you so much for being here, Dr. Levine. I'll turn it over to you now.
Great. Good afternoon and good morning to everyone. Thank you for joining us today. If at any point during the presentation my audio breaks up for any reason, please do let me know and interrupt me so I'm not talking to myself. But thank you all for joining me today. In the next 30 to 40 minutes, I'd like to review some of the latest developments in screening and treatment for ovarian cancer. Let's see here. This is my group that does all the work with us at NYU. On the left side, you can see my laboratory. On the right side, you can see our group of, I guess, about 11 or 12 GYN oncologists. We have campuses in Manhattan, Brooklyn, and on Long Island at Winthrop. On the bottom left are the funding organizations that support our research, and our hotline, if you need to reach us, is listed there, 8447-GYN-ONC. and a view of our new hospital in Manhattan can be seen from the East River. So today I'll review the origins of ovarian cancer, novel approaches to early detection, current options and clinical trials for risk reduction, and then some new information that's come out of our annual meetings over the past spring and summer, which were of course held in virtual formats. But we have some new information regarding surgical resection of recurrent ovarian cancer, a PARP inhibitor maintenance therapy, and some novel combinations. We'll then take questions and hopefully provide some answers. And I just want to begin by thanking all the patients who participate in clinical trials and help to make the future of cancer care more successful. I also want to acknowledge the presenters, some of which their slides have been borrowed and or stolen for this presentation. Another reminder, all women with ovarian cancer or a first-degree relative with ovarian cancer should be tested for mutations in BRCA1 and BRCA2 and often now other genes that can lead to inherited breast or ovarian cancer. We have many good ways to prevent these cancers that we'll talk about briefly, but it's important to remember that everyone with ovarian cancer or first-degree relatives should have genetic testing. Another reminder that some of you may have heard before and are aware, ovarian cancer does not really originate in the ovary. It originates in other sorts of pelvic tissues. So we think that the most common type of ovarian cancer, called high-grade serous ovarian cancer, develops most of the time at the end of the fallopian tube. And then we think the next two most common types, clear cell carcinoma and endometrioid ovarian carcinoma, develop from endometriosis, which is essentially related to the inside of the uterus. And so that theoretically means that ovarian cancers really don't come from the ovary. They just occupy the ovary and grow on the ovary. And we will not change the name of the cancer. We'll still call it ovarian cancer, but the actual cells that turn into cancer probably originated from someplace other than the ovary prior to becoming cancers. We now have identified a precursor lesion in the fallopian tube called a serous tubal intraepithelial carcinoma. And since that's quite a mouthful, we refer to it as a stick lesion. These stick lesions are very common, that we see them when we remove the ovaries and fallopian tubes to prevent ovarian cancer. We also see them more than half the time when we take out, when we do surgery for advanced stage ovarian cancer. If we can identify the fallopian tubes and can look inside of them, we find these precursor stick lesions 50 to 60% of the time. And people will ask, well, why is it not 100% of the time? And a couple of reasons for that is that sometimes the cancer itself can overgrow the fallopian tube and we just can't identify the precursor lesion anymore. And sometimes the fallopian tube cell may leave the fallopian tube and rest or sit on some other structure like the ovary and then turn into cancer in a different location, even though it originally came from the fallopian tube. And that is now referred to as something called the precursor escape phenomenon. And so I haven't shared all the gory data with you, including pictures of cancers and animals and stuff like that, but just to suffice it to say that many lines of evidence lead to the conclusion that most high-grade serous ovarian cancers appear to arise from the end of the fallopian tube, and this is based on both genetically engineered mouse models, data which I did not discuss obviously, genomic and genetic studies where we look at the gene expression profiles of cancers and normal tissues and do various comparisons, as well as looking actually at human tissues from women who do develop ovarian cancer. So that's the conclusion as to where we think ovarian cancer comes from. And since we now know that, we now believe that most cancers begin in the fallopian tube, as you can see, I think on the right side of this slide, the fallopian tube and the uterus and cervix are all connected to the outside world, which gives us access to get closer to the area where precursor lesions may develop. And so that's really revolutionized our approach to trying to find biomarkers of early detection. And we're going to talk both about early detection and prevention in this seminar. So I just want to clarify that when we prevent ovarian cancer, you never get ovarian cancer. Early detection is actually detecting real ovarian cancer at a stage when it's hopefully highly curable, and stage 1 ovarian cancers are highly curable, and advanced stage ovarian cancers are more difficult to cure. And so prevention is better because then you never get ovarian cancer. Early detection is very good and also very challenging. And so we spent a lot of effort on early detection. One of my funding organizations, the Honorable Tina Brosman Foundation, is completely dedicated to the early detection of ovarian cancers. And we've done a lot of studies over the years, both in my own laboratory and around the world. And initially we measured ovarian cancer biomarkers in fluid from the uterus, which we call uterine washings or uterine lavage. And we found that ovarian cancer biomarkers are many times more concentrated in the uterine washings from women with ovarian cancer than from women who do not have ovarian cancer. And they're also at much higher concentration from in the uterine washings than they are in a blood specimen. This has led to other approaches, including collecting DNA from tumors that we can identify both in pap smears and tampons, which can come from the cervix and vagina. And we have been successful in finding these mutations that are linked to cancers in these specimens, but we still haven't been able to confirm that we can do it reliably from early stage cancers. And that's very difficult. And that's sort of where a lot of the research is going nowadays. So just to review some studies that have come out in the past couple of years. 2 years ago, the group from Hopkins developed a highly sensitive test to identify tumor DNA in the blood. And they said they can identify almost 100% of samples. They could almost identify 100% of ovarian cancer cases have DNA that can be detected in the blood. But unfortunately, most of those cases were from women who had advanced ovarian cancer or advanced stage ovarian cancer, which of course is the most common presentation of ovarian cancer. And they concluded that these cancers are surgically resectable. Unfortunately, we're quite good at identifying advanced stage ovarian cancer nowadays with CT scans and other reasons, other modalities. But we actually want to identify stage 1 ovarian cancers. And so, so this is a nice, approach showing that it's theoretically possible to identify cancers in the blood, but we would like to do better than this and identify the cancers at an earlier stage. So that led to a number of other approaches, including using both pap smears and endometrial sampling and blood samples in combination. And you can see on the left side that for ovarian cancer, using either pap samples or tau brush samples, which are samples from the inside of the uterus, we could identify a little bit less than half of ovarian cancers, which of course is not sufficient. On the right side, when you put both of these approaches together in combination with blood or plasma samples, we can now identify just over 60% of ovarian cancers. And so the combination is a little bit better. And for early stage ovarian cancer, this approach could identify about half of all ovarian cancers, which is good, but certainly not good enough, but you do have to start somewhere. So a lot of these things are sort of our investigations into pilot approaches to how we can do this. And then over time, things will and do always improve and get better. This study is from a group in Austria, in Vienna. Paul Spicer, who's the penultimate author here, actually developed a very good catheter to collect fluid from the uterine cavity, because that is challenging for different technical reasons. And he developed a very nice multi-channel catheter that allows us to sample fluid and washings from inside the uterus. And he did this in about 20 patients, 10 people with cancer and 10 people without cancer. And he was quite successful in identifying 8 out of 10 patients with cancer had DNA that was detectable with a highly sensitive assay from the uterine washings. These patients all had advanced stage ovarian cancer. So again, a pilot study. The interesting thing was that We also identified cancer-like mutations in the washings from women who did not have cancer. And so this gets to what we call specificity. And not only do we have to identify the mutations, we have to make sure they're the ones that come from ovarian cancer and not ones that just develop through the process of aging. And so as you age, all of your genes and your DNA does develop mutations. And normally, most of these mutations are what are called passengers that do not lead to cancers, but they can look like cancer mutations. And part of the complexity now is to differentiate passenger mutations from the driver mutations that really do cause cancer. And so this will be a challenge moving forward with these highly sensitive approaches. This is an interesting study from Italy where they also published earlier this year, where they actually looked at pap smear samples, and they had collected and stored pap smear samples here from 17 women who had ovarian cancer, and they had multiple pap smear specimens from some women that had been stored prior to a diagnosis of ovarian cancer. And in 11 out of 17 cases, so just about 65% of the cases, they could identify ovarian cancer related mutations in a gene called TP53 in the pap smears before the ovarian cancer diagnosis. Now, in 2 of these cases, they had a specimen that was 4 to 6 years before diagnosis, which is really phenomenal. And they were able to identify cancer-associated DNA in those specimens, again, many years before a diagnosis. In some cases, they could not do that. And so, again, a very fascinating proof of principle. We're not sure, if this would occur frequently enough to make it useful, but again, something that's being worked on and has interesting promise. Finally, just to transition a little bit towards prevention, I want to emphasize the fact that birth control pills or oral contraceptives are highly effective for ovarian cancer risk reduction. If you take birth control pills for 5 years or more, you probably reduce your risk of ovarian cancer by 30 to 40%. And that's been well established over decades, and it's very reliable. And we do recommend birth control use for women who are younger and are known to be at high genetic risk of ovarian cancers. So from all of this data I've presented so far, one of the logical conclusions, of course, is if we remove the ovaries and fallopian tubes in high-risk women, this is a highly effective method for ovarian cancer risk reduction, and this is the standard of care. The top table here shows you that there's about an 85% risk reduction from BRCA1 associated ovarian cancer if you do remove the ovaries and fallopian tubes. Just to wrap up the screening a little bit before I go on to prevention, I just want to comment, and I failed to include a slide on this, but I just want to comment that ovarian cancer screening with either ultrasound or sonography or a blood test called CA-125 for the purpose of screening is not effective in the general population. We recommend against doing screening in the general population because it does lead to more harm than benefit. In the high-risk population, specifically women who have inherited mutations that put them at high risk for ovarian cancer, it's unclear whether screening is useful. And then, so in that population, we recommend that screening can be considered. And that's a discussion to have with your genetic counselor or your gynecologist, or preferably your GYN oncologist. And so something to consider in the high-risk population, but recommended against in the general population. I have many women who come into my practice who had a sonogram just because a doctor wanted to check on the ovaries, and that often leads to an unnecessary operation. And so we do want to emphasize that ovarian cancer screening is not recommended for women who are at average risk. So moving on, now that I've hopefully convinced you that most ovarian cancers begin in the fallopian tubes, the logical next step would be, well, can we just take out the fallopian tubes to prevent ovarian cancer? So it's a big leap from knowing or thinking that they begin in the fallopian tubes to assuming that if you remove them, that will prevent ovarian cancer. So as of now, just removing the fallopian tubes is unproven and experimental. This is a study called the WISP study, sponsored by Stand Up to Cancer, the Ovarian Cancer Research Fund Alliance, and the National Ovarian Cancer Coalition, and AACR. It was run out of MD Anderson with extensive collaboration from the University of Washington in Seattle, and 9 centers accrued over 200 women with various genetic risk factors to the study of salpingectomy followed by oophorectomy to ask the question whether salpingectomy will improve sexual functioning and menopausal symptoms compared to the standard risk-reducing salpingo-oophorectomy. And in fact, the data was presented earlier this year at one of our meetings. And in fact, it is true that if you do not take out the ovaries, you will have less menopausal symptoms than if you do take out the ovaries. And this was really, a demonstration project. No one really thought that wouldn't be the case, but since the purpose of not removing the ovaries is to prevent menopausal symptoms, we did have to prove that that was true. And we did that as part of this study. So then the question is, if you want to show that just removing the fallopian tubes can prevent ovarian cancer, which we call efficacy, if you want to prove efficacy, how do you do that study? And that's very complicated. So in the bottom of the slide, I'm showing you a figure from a paper in JAMA from 2017, where they studied many BRCA1 and BRCA2 carriers. And what you see here is the risk of ovarian cancer among BRCA1 and BRCA2 carriers. And basically for BRCA1 carriers, the lifetime risk of ovarian cancer is about 40%, but the risk between age 40 and 50 is approximately 1% per year. For BRCA2 carriers, the lifetime risk is approximately 20%, but most of those cancers don't begin until about age 50. And so that's why our standard recommendations for removal of the ovaries and fallopian tubes, called a bilateral salpingo-oophorectomy. For BRCA2 carriers, we recommend that to happen about age 45. Since there's not that many cancers until age 50, we want to get this accomplished before that frequency increases. And yet for BRCA1 carriers, we do suggest that this happens before the age of 40. And so since the purpose of just removing the fallopian tubes or salpingectomy is to prevent premenopausal ovarian cancer, we really have to study only BRCA1 carriers who are premenopausal to see if this approach makes sense. And so after many years of designing a study with some very nice input from FORCE, which is a co-sponsor of today's seminar, we really appreciate all the support and input we've received from FORCE. The NRG Oncology Cooperative Clinical Trial Group, which is a group that conducts trials throughout the world, has designed and opened a trial called NRG CC008, which is easier known as the SOROC trial. It's now open, and it's a non-randomized prospective clinical trial comparing the non-inferiority of salpingectomy to salpingo-oophorectomy to reduce the risk of ovarian cancer among BRCA1 carriers. What this means is, basically, is salpingectomy equivalent to salpingo-oophorectomy? Based on various statistical approaches, we can't really use the term equivalent. We can just ask the question, is it not worse? Which is sort of the, I guess a synonym for equivalent, but really we know that removing the tubes and ovaries is the standard of care. And so if we just remove the fallopian tubes, we want to make sure that's not worse. And that's what this study will do. The study launched on June 23rd. It's now open at 27 sites across the US, including the NYU Langone Health Perlmutter Cancer Center in New York City. And so we are available for any patients who are interested in this study. This study will test the hypothesis that salpingectomy is not inferior to salpingo-oophorectomy. Patients will be premenopausal between age 35 and 50 and have a BRCA1 mutation. It's not randomized because we thought that would be unethical. And so patients will self-select one of the 2 treatments. The standard of care is recommended, and salpingectomy is recommended for people who decline or refuse to have the ovaries and fallopian tubes removed, mostly because many women do not want to go into menopause prematurely. We do know that about 40% of BRCA1 carriers do not have their ovaries and fallopian tubes removed by age 40, and that's the specific target population for women who may want to have a salpingectomy instead of not doing any preventative surgical approaches. Everyone will have a preoperative sonogram and CA-125 tests that are normal. And this is a very user-friendly study. All the follow-up can be done in person or remotely. We do have an annual blood sample of CA-125 and research bloods. More information for this trial can be found at clinicaltrials.gov or through NYU Langone Health or other centers that have already activated the study. There's a schema on the left, which is probably difficult to see. Basically, the point there is if you have a salpingectomy, you can convert over to having the ovaries removed at any time, and we do recommend that, that does happen after having salpingectomy. On the right side are a number of survey instruments that measure patient-reported outcomes, and the other user-friendly aspect of this study is that all of the patient-reported outcomes can be completed on your iPhone or Android device through an app called ePro, which is free to download. And so there's no need to send in survey instruments or complete them in the office. You can do them on your iPhone or iPad or Android device at your convenience. It takes about 20 to 30 minutes every 6 months for the first 2 years to complete these surveys. So finally, moving on to the treatment side of things, just a reminder that the standard treatment for advanced stage ovarian cancer is to start with a surgical operation called cytoreduction or debulking. The purpose here is to remove all the cancer that we can see with the naked eye. This has been associated with the best outcomes in many trials over many years. Sometimes that's not technically possible, in which case almost half the time we actually give chemotherapy first and then do surgery later. When we do surgery first, when we can, we then go on to give chemotherapy, and then most patients will go into remission, and that'll be followed by a period of observation using CA-125 and CT scanning. And if the cancer should come back, we often can treat it again very successfully. So this is just a figure to show that when we can remove all the surgery, when we can remove all the cancer that we can see with the naked eye, it's highly effective, whether we do this at the time of diagnosis or now occasionally when a surgery may come back in the future. So a couple of studies that came out this year that are interesting. One of our controversial questions is whether surgery is useful when cancer comes back. So those of us who are surgeons, we often recommend surgery. We enjoy doing surgery, and it makes a lot of sense, and it works very well. But we've never really tested the hypothesis that maybe surgery is no better than not doing surgery. And so a German group called the AGO have done a number of trials in this area. They've developed a criteria as to who they think are good surgical candidates when cancer does recur. The criteria includes having cancer that's completely resectable, having no ascites, having a reasonable time period from prior treatment. And they call this the AGO score. And they randomize patients to either have surgery followed by chemotherapy or just chemotherapy alone. In a high proportion of patients, I believe about 80% or so, they were able to remove all of the cancer. And so this study included more than 400 patients. It's a very good sized study. 3/4 of the patients had been more than a year after having prior platinum-based therapy. The average was about a year and a half since prior platinum-based therapy. Most patients had serous histology and advanced stage disease. And you can see here that for those people who had surgery with complete resection, which again is a subset of everyone who had surgery, compared to patients who did not have surgery, they had a very good outcome. That was about 30% longer overall survival than patients who did not have surgery. So this just suggests that when you can have surgery with the idea that the disease will be completely resected, then that can be helpful for helping people to live longer and better. So it's the first prospective randomized trial showing a benefit to cytoreductive or debulking surgery in recurrent ovarian cancer. Patients are highly selected to have a good amount of time since the prior treatment and have other features that suggest that the disease can be completely resected and also will respond to chemotherapy after surgery. There's a number of other trials ongoing asking this question, and those will be reported in the future. But this is one of the best well-designed studies done by a very talented group of surgeons, suggesting that when surgery is done at an ovarian cancer center of excellence that has, experience treating advanced ovarian cancer and experienced surgeons, that this can be very, very beneficial. This other study here, the SOLO2 study, is a study of maintenance olaparib, which is a PARP inhibitor, which many people have heard of and has been a real wonderful revolutionary drug specifically for ovarian cancers associated with BRCA mutations, and has also been useful for a number of other types of ovarian cancer. All this gets fairly complicated because we do molecular profiling now to categorize ovarian cancers into different molecularly defined subgroups, and this has really been helpful to date and will become more important in the future as we really individualize all of our treatments for women who have ovarian cancer. This is the final results of a study on the background, knowing that ovarian cancer often comes back and often can be difficult to treat, but PARP inhibitors can be very helpful. And so here, this study randomized patients a number of years ago to either get olaparib, which is a PARP inhibitor, or a placebo. These are patients who had already received platinum-based chemotherapy and they had a good response to treatment. So most people had a complete response, some people had a partial response, but the platinum-based therapy was working to a greater or lesser extent, but it was working. And this study added the data for about 300 patients. They were randomized in what's called a 2-to-1 fashion, so twice as many people got the PARP inhibitor as had gotten the olaparib. Most people typically had high-grade serous ovarian cancer because that's the predominant subtype associated with BRCA1 and 2 mutations. And again, 2/3 of the patients had BRCA1 mutations and 1/3 had BRCA2 mutations. But the take-home point here is that those patients who received olaparib had a much better and longer quality of life. The number of people who are alive and without treatment, alive and without disease after 5 years was at least twice as high in the olaparib group. And you can see at any point here, along the time scale, there was a much better outcome for patients who were on the maintenance olaparib, reflecting a very strong benefit of olaparib, which we now use in patients with BRCA-associated ovarian cancers routinely. This study is only slightly outdated because now we often treat patients earlier with PARP inhibitors. And this study included people who had no prior exposure to PARP inhibitors. And so in that situation, when there is no prior use of PARP inhibitors, this is a very useful approach. Now, PARP inhibitors are pills and they're taken orally. So everyone thinks, wow, that's really nice. But these PARP inhibitors and all oral medication that we use are real drugs, and they're real strong drugs. And in fact, here, the part that I circled, about 20% of people who received the PARP inhibitor olaparib had what's called grade 3 anemia, which is very serious anemia that frequently or almost always will require a blood transfusion. And so these are real drugs with real side effects. There's some nausea, there's some tiredness that are all increased with the drug. So it really works, but there are definitely real side effects. And so for someone with a BRCA mutation, the benefit is so strong that we would very strongly recommend a PARP inhibitor. But nowadays, PARP inhibitors are approved almost for everyone with ovarian cancer, but for some subtypes and subgroups of ovarian cancer, the benefit may not be so strong. And then it's a very important decision to try to balance and consider the benefits of the PARP inhibitor with the side effects and the risks and toxicities of the PARP inhibitor, something that's important to discuss with your oncologist. Finally, this last study I want to talk about uses a PARP inhibitor in combination with a drug called cediranib. Here on the next slide, olaparib, as we know, is a PARP inhibitor. Cediranib is another oral drug, and it targets blood vessel formation. So it's called an anti-angiogenic drug. It's also a pill, an oral medicine, also has real strong effects and real strong side effects. And this targets blood vessel formation, because without blood vessels, of course, a cancer can't survive. And so here in this study, this also was asking the question as to whether we can treat recurrent platinum-sensitive ovarian cancer with a oral regimen of medications that does not require intravenous treatments. And so here, patients were randomized to regular chemotherapy, to just the PARP inhibitor, or the combination of the two oral drugs, the PARP inhibitor and the anti-angiogenic agent, or olaparib and cediranib. Again, this was a very large study. Almost 500 plus patients were enrolled in the study in 3 different treatment arms. Most patients did not have a BRCA mutations, but we will look at that separately. You can see here that there was a very good response to both the chemotherapy and the combination treatment. The overall response rate here is about 70%, which is quite excellent. It was actually less for the olaparib alone. Here we see the analysis for those patients who had BRCA mutations, which was a smaller subset. And here we see that the combination and the oral drug were both as good, if not better, than the chemotherapy. And so this really shows that for BRCA-associated recurrent ovarian cancer, a PARP inhibitor is very good treatment. The combination did not really seem to be that much better. And so if someone has not yet received a PARP inhibitor, at recurrence, a PARP inhibitor is a very good treatment for BRCA-associated ovarian cancers. This is interesting in that for those tumors that did not have BRCA mutations, the chemotherapy and the combination of the 2 oral drugs seemed to do just as well. No combination was superior to chemotherapy, and the purpose of the study was to see if one of the 2 experimental arms was better than chemotherapy. And so this study did not prove that. So we can't say that these combinations are better than chemotherapy. And the purpose of the study was not to measure if they're equivalent, because that does require a larger study. So this does not definitively prove that they're equivalent, and these are not FDA-approved drugs right now, but this suggests that it's possible to take oral agents instead of intravenous chemotherapy, and it's possible to not use a platinum drug in platinum recurrent ovarian cancer, and it might be just as good, but that's not completely proven yet. Again, all these drugs do have real side effects. You can see here that the chemotherapy gives anemia, the drugs give anemia, the drugs can also reduce the white blood cell count. Here as well, the combination therapy is kind of tough to tolerate. It gives a lot of diarrhea, it gives a lot of fatigue, it raises blood pressure. So these are pills that we take, but they're real drugs with real strong good effects and some real strong not so good effects. And so all of this has to really be individualized with your doctor. So in conclusion, this study did not show that the combination therapy was better, but it does suggest that an oral regimen that doesn't include platinum-based chemotherapy may be almost as good as platinum-based chemotherapy, but we will need further studies to actually test that question, because oftentimes what we think might make sense truly doesn't make sense and doesn't work as well as we'd like it to work when we do test it in a clinical trial, just showing how important it is to actually do clinical trials to really develop the next generation of treatments. So just to wrap up and conclude, some take-home points: all women with ovarian cancer should have germline genetic testing. Established ovarian tumors likely come from a precursor lesion in the distal fallopian tube. We are working on lots of novel approaches to early detection that are promising but need further testing. Removing the ovaries and fallopian tubes, as well as taking birth control pills, are both highly effective approaches to reduce the risk of ovarian cancer. Taking out just the fallopian tubes is certainly feasible. It does avoid surgically induced menopause, but it remains unproven and experimental as of this time. There are clinical trials ongoing, including WISP and SOROC, and you can find these on clinicaltrials.gov and at NYU Langone Health. So please reach out if you or anyone else you know is interested in these trials. They're available on multiple websites. Secondary cytoreductive surgery can prolong ovarian overall survival in highly selected patients with recurrent ovarian cancer. PARP inhibitors dramatically extend survival in BRCA carriers when used as maintenance therapies. And we have other agents that are very promising as alternatives to chemotherapy and simply increasing the number of options we have available for women who have recurrent ovarian cancer. And so we're making a lot of progress. I just like to say that, you know, people with ovarian cancer are definitely living longer and better. Many of our treatments are also less toxic and easier to tolerate. Things are getting better every year for ovarian cancer. We certainly are not doing enough. We certainly are not curing enough patients, but we're making a lot of progress in the right direction. So thank you for joining us this afternoon and staying on for the past 40 minutes. And I'd be happy to take any questions.
Great, thank you so much, Dr. Levine. So we're gonna get started with the Q&A. You still can submit questions in the question pane in the GoToWebinar control panel. We will try to get through all of the submitted questions, but we may not be able to due to time constraints. Okay, so this question is about have any of the tests that they are studying for early detection, pelvic washings, P53, have they been studied for detecting recurrence?
No, mostly because the CA-125 blood test is highly effective for detecting recurrence. We measure it usually just before diagnosis, and that is a wonderful marker when it is elevated. The other problem, of course, is that removal of the uterus is usually part of the initial treatment of ovarian cancer, so therefore that's not available to be used, you know, in the future. We do have some blood-based biomarkers we can use to detect recurrent disease, but the CA-125 is so effective that we would not use those in most cases.
Okay. In the study, you were talking about surgery during recurrence. Were those patients on PARP inhibitors as well?
So they were not on PARP inhibitors at the time. They all had received previous chemotherapy and they were basically in remission until the recurrence was detected. And then the purpose of the study was to ask the question, should they have surgery first followed by chemotherapy, or should they just get chemotherapy? A PARP inhibitor, of course, is a type of chemotherapy. It's a type of drug that we use to treat cancers. And so that would be a reasonable question, should someone have a PARP inhibitor versus surgery? That was not specifically asked, you know, in that research study, but that's a type of question that an oncologist would incorporate into some recommendations.
Mm-hmm. So this question is about HIPEC, and it says HIPEC seems to be having a moment. What are your thoughts on it?
Not sure exactly which moment someone may think it's having, but HIPEC is popular and discussed and controversial. And basically there was one well-designed randomized trial that came out a year to 2 years ago from Europe, suggesting that when HIPEC is used after neoadjuvant chemotherapy at the time of what's called interval cytoreductive surgery. So this is for people who have not had initial surgery first, but got chemotherapy first. It worked pretty well. After 3 or 4 cycles, they go to the operating room to have the rest of the cancer taken out. Once it's all taken out, at the same time in the operating room, they give heated intraperitoneal chemotherapy, which is what HIPEC stands for, and then go on to receive more chemotherapy. In that situation, this study randomized patients to HIPEC or no HIPEC, and those who received HIPEC did much better. It's only one study. It almost seems too good to be true, but the one study suggests it's very effective. Some people think, well, it's just because they get an extra cycle of chemotherapy, but that doesn't really make sense based on a lot of other data that we are aware of. It's a highly selected group. So 1, they responded to initial treatment. 2, they had all the cancer removed. at the time of interval surgery, and then they get the HIPEC. So that's reasonable. I do that in my practice. I recommend it in my practice, and we incorporate it on a regular basis. People are trying to use HIPEC in different situations, which makes sense in a research setting, but it's unproven to work in other settings. Some of my colleagues tested HIPEC at the time of recurrent cancer, and that was not shown to be effective in that particular research study. The other thing to keep in mind is some of the older studies in HIPEC were simply retrospective reviews of the people who happened to get HIPEC, and they were not randomized. And so those patients were highly selected, and they also happened to do very well. So they may have done very well because they got HIPEC, but they may have just done very well because they were a group of patients who normally would do quite well, such as people who could have surgery in the first place to remove recurrent disease. So HIPEC is promising. There is some data to support that it works in a very specific indication. To use it beyond that, I would not recommend outside of a clinical trial.
Okay, great, thank you. This question, we hear a lot about immunotherapy, yet so far it does not seem to work that well for ovarian cancer. Pembro alone is about 9% effective. Do you have any thoughts about what might be promising for immunotherapy in ovarian cancer?
Sure, that's a great question, and what the person asking the question indicated is absolutely correct. Immunotherapies work very well for many cancers, but not yet for ovarian cancer. It's very challenging, and it's going to be difficult to figure it out for the following reason. Excuse me. Ovarian cancer has what's called an immunosuppressive environment. And so the immunotherapy drugs like pembrolizumab, they basically unmask the tumor so that the immune cells can see the cancer cells and attack them. And that works very well in many types of diseases. But in ovarian cancer, there's also immune cells that turn off the immune system. So it's not that the cancer cells are hidden, they also have immune cells working against them so that your own immune cells can't find the cancer cells and attack them. And so we're pretty confident now that immunotherapy by itself is not going to work well in ovarian cancer. And so we're now trying to combine immunotherapy with other approaches where we can overcome what I call the immunosuppressive microenvironment that exists in ovarian cancer. So there's many trials now that are testing immunotherapy. They're very promising. We have at least one, if not two trials open at NYU Langone Health. One is in the initial setting where the combination of regular chemotherapy we're giving with or without immunotherapy in the context of a clinical trial. And the idea here is that the chemotherapy itself will help to make the tumor more visible to the immunotherapy. So maybe it's a combination of chemotherapy and immunotherapy that's needed to make the immunotherapy work. In my laboratory, I'm working on another approach where we're combining different types of immunotherapy for some very specific types of ovarian cancers where we also think that specific types of immune cells need to be targeted. So there's lots of laboratory research going on, which is also very challenging because our animal models don't usually have an intact immune system. So it makes those studies very challenging. We hope that we're going to figure this out, and we're working very hard at it. But as of now, immunotherapy itself has not proven to work as well as we would like it to. I would encourage everyone to enroll on clinical trials of immunotherapy when they make sense for you. And that's sort of the status of where things stand as of this time.
Great, thank you. Okay, so this is about PARP inhibitors and your thoughts on trying a second PARP after seeing progression on a first PARP.
Yeah, so PARP after PARP has been looked at a little bit. It's not that promising. Most of the PARP inhibitors work in a very similar manner. There's reasons to pick one PARP inhibitor over another one, but it's not really because one works so much better than another one. And in fact, many of them are very similar. When one PARP inhibitor stops working, most of the time the tumor has developed a mutation to overcome or counteract the mechanism by which PARP inhibitors work. And so simply PARP after PARP, I'm not a big fan of. We do have some studies where we're combining PARP inhibitors, particularly with immunotherapy, and that's also very promising. There's a lot of scientific and biologic reasons why PARP inhibitors combined with other drugs might work. So taking some PARP combination after PARP inhibitor makes sense to me. Those are only available, as far as I can think right now, on clinical trials. So that makes a lot of sense. Hasn't been proven yet, but just a PARP after PARP for most people, I would think does not make that much sense, with rare exception.
Mm-hmm. Great, thank you. This question, can males pass on the BRCA gene to female children? Is genetic testing suggested since my husband's mother had breast cancer?
Yes, that's a very good question. I won't answer whether because of your husband's mother, et cetera, but the general question is yes, inherited mutations are passed from parents to children, no matter what sex or gender you may be. And so anyone can pass a gene on to any child. Obviously, women generally get more BRCA-associated cancers, although male breast cancer, pancreatic cancer, and prostate cancer are well known to be associated with BRCA mutations. And of course, men can get male breast cancer, not so common, but also prostate cancer and pancreatic cancer. Whether or not someone should be tested does depend on the family history, age of onset, and that's really why you would meet with a genetic counselor or a well-informed oncologist or gynecologist. Obviously, it's easy to get tested with a blood test. Whether it's the right decision for individual person usually requires some counseling, but the simple answer is yes, men can pass these on to their male and female children. And so anyone should be tested who is appropriate for genetic testing in general, whether you're male or female.
Mm-hmm. Great. Can you comment on CAR T cell therapies in ovarian cancer?
A little bit. So CAR T cell therapies is really an approach that's fascinating, complicated, and expensive, where you take someone's own T cells out, immune cells. T cells are immune cells. So you isolate someone's own immune cells, you take them out of the body usually, you expose them to someone's own tumor or to something else, and you sort of, or you turn the T cells into different types of T cells that are likely to target ovarian cancer for some specific reason, because the T cells are either engineered to specifically target ovarian cancers in general, or some protein that many ovarian cancers will express, or they can be also targeted to or engineered to someone's own tumor, which is called adoptive T cell therapy rather than CAR T cell therapy. In CAR T cell therapy, the T cells are engineered to express a marker that would target ovarian cancer. There's some very promising results. It's a very intensive process for the patient and a laboratory. So right now they're only really available to highly selected patients on highly selected research studies. If these work and show great promise, it'll be a challenge to make them widely available because the process is quite labor intensive and expensive. Although if it's works well enough, I'm sure that we as scientists and patients and doctors and politicians will figure out how to do it. So there are some very impressive responses, but it's in a small number of patients. So more to come. If anyone's eligible for a CAR T cell trial, if it's a good research trial at a good research institution, I would suggest that it's a very good thing to do. Many people are not eligible for these trials because they have very strict inclusion and exclusion criteria.
Great. Is Avastin being used as prophylactic treatment now in addition to recurrent treatment?
So we use Avastin a lot, which is also called bevacizumab or Bev. It works pretty well. It's not one of our best drugs. It works a lot of the time for most people, but it only works sort of, a little bit. It doesn't usually cure patients. But I think the term this person might use is preventative treatments. And I think what they might mean is something called maintenance therapies. And so the way that we use bevacizumab is if someone's received bevacizumab, typically in combination with chemotherapy, and they've had a good response, we then continue the bevacizumab as maintenance therapy. The data suggests that you have to take the bevacizumab for a long time to get a small to medium benefit. So you're on the drug for many months, and the data suggests that it sort of helps you live only a few months longer. It's pretty well tolerated. It gives high blood pressure and sometimes kidney problems and rarely serious complications. And so since we don't have many great alternatives in some situations, we do use it. And so in my mind, I categorize it as a good drug, but not a great drug.
Mm-hmm. Great, thank you. This question asks, which targeted therapies being explored seem to be most promising? For example, XMT 1536-1 or mirvetuximab have both been fast-tracked by FDA.
So I'm not familiar with the first drug called XMT. I don't know what it is. So maybe if it's known by a different name, I might. Mirvetuximab, or however we say that, is a folate receptor alpha drug. It showed a lot of promise because about 60% of ovarian cancers will express a protein called folate receptor alpha, and this is a sort of an antibody-directed therapy that targets folate receptor alpha. A large trial was just finished that was negative, so that's not so great. They looked at this subset of patients who had really high expression of the folate receptor alpha, and they found in that subgroup it works better. But again, that wasn't the way the trial was designed. And so I think it does hold some very decent promise that for tumors that have very high expression of folate receptor alpha, it could be a potentially good drug. I don't know if it's actually FDA approved. I think the fast track just means they're getting some benefit in the clinical trial design. And so I would be interested to see that trial sort of done again in a more select subset of patients. Unfortunately, what drug companies will often do is they'll try to look for a very broad indication because that helps the most people and also makes the most money. But truthfully, if you have much better biology, you can see a much better effect, and then a subset of patients will get a really good response instead of trying to mix up the good responses with the not such good responses. So it's possible that mirvetuximab will be promising in that group of patients, but we will have to wait till that clinical trial is complete. And I will look up the other drug and see if I know it by another name or if I can learn something.
Yeah, I haven't heard of that either. Okay, this question is about what treatment to try when nothing has worked on platinum-resistant high-grade serous ovarian cancer.
Right, so platinum-resistant high-grade serous ovarian cancer is always a challenging situation that unfortunately a number of patients find themselves in that situation. Clinical trial that makes sense is always the best option because it has, hope to work well where other drugs may not work well. After receiving a number of other types of chemotherapy, the chance that more chemotherapy will work well sort of goes down a bit. And so I always recommend a clinical trial. I can't really give a specific recommendation here, on a webinar. But the other thing I just want to mention is that when someone is sort of running out of treatment options, we have a fairly good data that sometimes not receiving more treatment can actually help someone to live longer and better than receiving more treatment that has a fairly low, chance of success. So we definitely want everyone to live as long and as good as possible, but there sometimes comes a time where the balance of long and good can be a difficult challenge to work out.
Great. So I think we have time for one more question. And this is, what is your opinion of PARP maintenance for BRCA negative?
So good, a great question to end on. So just to remind people, for BRCA positive, PARP maintenance is practically a miracle drug. It's wonderful. For BRCA negative, we have multiple groups. So now this is where I was alluding to in the lecture part, that we do molecular testing. It's getting quite sophisticated nowadays. We actually can subcategorize the BRCA negative population into a number of other groups. The most common one is called HRD, which stands for homologous recombination deficient, which really is a type of DNA repair, but suffice to say that's a different lecture. But for people who have this DNA defect called HRD, that can happen without a BRCA mutation, and PARP inhibitors there also work quite well, and so I'm quite supportive of PARP inhibitors in that population. And the final population is what I call the negative group. So there's no BRCA mutations and there's no HRD. Sometimes we call that HRP, for homologous recombination proficient. I call that the negative group. And there, PARP inhibitors work a bit, just like bevacizumab works a bit. So they can be helpful, but they also have real side effects of anemia and needing blood transfusions. And so I discuss it with my patients, would you like to take the PARP inhibitor, or would you like to go to the beach? Just meaning that, the PARP inhibitor is going to make you tired, it might make you nauseous, there's some small but real chance you'll need a blood transfusion, and it might interfere with your quality of life. And so we have a very candid conversation about whether, in this situation, taking the PARP inhibitor makes sense. But all of this conversation relies on the fact that we've done the molecular testing. We know how to interpret the results that get back to us from a drug company or a laboratory, because interpreting the results is also important. And of course, we have to know the clinical trial data. And so it turns into quite a lengthy conversation to make that decision. But there's very important things to consider, because the PARP inhibitors do work, but they also come with some side effects. But this is an example of how, it's really good to have treatment options. They're working really well for some patients, and they're working pretty well for many patients. And so we really are making great progress. PARP inhibitors have been great. I fully believe that immunotherapy is going to catch up. We have other targeted agents. We have subgroups of patients where we're finding even more novel drugs. And so things are really moving in the right direction. And with the collaboration between doctors and scientists and patients, we can really continue to make a lot of improvement. And thank you all for joining us today. It's always a pleasure. And I hope everyone has a great rest of the day.
Yes, thank you, Dr. Levine, for an informative program. And thank you to everyone who participated and for submitting all of these great questions. It was a great webinar and conversation. We'd ask everyone to please take a moment to fill out the survey at the end of the webinar. It may take a minute or two for the survey to download, but we use that feedback to improve our future programs. Thank you, everyone.